On post-op day 7, vision was 2 by 60. Patient was this retina was still attached under oil. However, on post-op day 15, patient developed a macular hole RD because of it. He was a high myope with a posterior staphyloma, and you can see the fluid, emanating from the macular hole and involving the posterior pole with the recurrent RD. Patient underwent revit with PFCL and ILM peeling and endolaser and re-SOI. And I'll show you the video, the combined video in the end, and was doing fine. And gradually, there was a small layer of SRF, at the posterior pole. Macular hole was closed post this second surgery. And this is how the progress was. And on post-op day 18, patient was doing well with a closed macular hole and attached retina with vision of 2 by 60. But again, on post-op day 30, vision was 3 by 60, but there was a recurrent inferior RD, and with the PVR at the posterior edge of the buccal. I'm not sure if you can see it very well here, but it's behind the lashed line. There are those membranes which are formed at the posterior edge of the buccal effect. Macular hole was still closed. So this is a kind of a summary of how the OCT behaved, and patient underwent this surgery, and I'll show you the video now. So of course, this was the initial vitrectomy which was done, and I don't use 23 gauge but 25 gauge, but I do make those changes that I do not use the trocars to go deeper into the eye. And also for the forceps, I use the catalyst forceps, which has a spring action, so it can go deeper into the eye and reach the posterior pole. So at this time there was choroidal detachment, and the IOP was very low. So it was demanding surgery, but I managed to settle the retina and do laser in the periphery as well and put oil. But post-op day 1, we saw that the patient had a macular hole, but the retina was still attached. So the second surgery will be the one that follows now. So air fluid exchange, and then made a retinotomy just inferior to the disc, and then changed the visualization system because my instruments were digging the lens again and again after staining with BBG, but because of lack of counter traction, I then put PFCL, and then managed to just plug the macular hole with ILM ERM complex under PFCL. And then started draining, and the PFCL, the subretinal fluid tract, actually it was not shown in this part of the video, and it came superiorly. I had to make a retinotomy there to drain that part of the subretinal fluid, but eventually I achieved drying, and patient was flat. And then I'll show you the third surgery where the inferior PVR was there, and so these are the membranes. Actually, this third surgery was done at Shroff Center by Dr. Darayas, because the patient took a third opinion there for, and then a Densiron procedure was advised, and these membranes were removed. And again, what Dr. Guha was showing earlier, a mixture of tug of war and then some ILM peeling, and this PVR was taken care of, and after laser, Densiron was injected. So patient is doing fine, and vision has improved to 636 parts with a very well attached retina, and inferior laser CRA in that area of recurrent PVR, and so that was my first case. So I'll just go over to the second case. It's not a very complicated surgery, but just a kind of a misadventure. 30-year-old male with a history of blunt trauma, secondary glaucoma with more than 180 degrees angle recession, already had a vitrectomy for vitreous hemorrhage in 2020, presented with stage 4 macular hole this time with a vision of 636. and patient was taken up for macular hole surgery. I'll just go to the video. So my fellow was doing this, and if you see now, there was a sudden gush of BBG because the plunger was a little, not, and he had not injected outside. So the BBG has, gone into and formed a bleb just inferior to the disc, and it's not coming out through the entry wound. So I had to make a retinotomy, and there is subretinal air as well, and maybe sub RP BBG as well. So I'm after extruding out the BBG, then I continue with the surgery for the macular hole. And once the plug is in place, I again try to drain as much BBG I can from the subretinal query sub RPE space as I can, and then left the patient with gas. So patient did well, and the main concern was the area of the the subretinal BBG, but fortunately the macula was not involved by this bleb formation, and eventually the patient recovered good vision with 618. And although it's not very relevant in this case, but we did do fields to see if there was any change, because of the subretinal BBG, and that is what it is. So this has been reported, but it's more relevant for the macular area. But just wanted to share that we can have this accidental, very rapid, injection of BBG, especially in the winter months. This happened in the peak of winter, so I'm not sure how much of the silicon, solidification inside the 2 cc syringe which we use. We use a BD syringe. We use a Dispovan, 2 cc syringe to inject the BBG, and and it was a vitrectomized eye, so there was nothing to stop that jet of BBG which pierced the area under the disc and formed the bleb. That was a learning thing for the fellow. Yes. Yes. The tuberculin syringe, you mean? Yeah. The only problem is that sometimes the plunger comes back a long way. Yeah. So that's the main reason we don't use the 1 cc, because the plunger comes back a long way, and that is what.
Any other comments or questions? MPS sir, any comments from you?
So mic.
Mic is there.
Can you please give the mic?
The first case, there was an ERM which had formed subsequently from the first surgery to the second surgery. In myopes, it's possible that like we may be missing the posterior, the skytic vitreous, which is that usually contracts and gives rise to the macular hole, or maybe the macular hole was there earlier, and the fact that it recurred because that the cortical vitreous contracted and probably peeled it off is what I would think. And the second recurrence, I'm not too sure if there's a missed break somewhere inferiorly which caused the second recurrence, where when the patient underwent surgery, additional surgery by Darius.
So actually, initially in the second surgery only, I had in the first surgery only I had done a lot of laser in the inferior retina, because I knew that it's the inferior PVR which kind of is troublesome. So I had seen laser kind of marks there. But I agree with you that maybe there was some skytic vitreous to which I couldn't remove to the best of my attempts.
Yeah, I would usually use triamcinolone multiple times in these patients,
yes.
And like you will see those very fine membranes stained with triamcinolone, which may not be possible to peel with the forceps also. That's what, like as I was mentioning yesterday, we can use the Wetzel sponge, the arrowhead sponges. So that's got a sufficiently rough surface. So you can cut a small piece of it, hold it in your forceps, and you can use it to swipe on the surface of the retina. That helps us to peel this hyaloid, which is on the surface of the retina. So you can use that to peel it. And it's a kind of an instrument which you can like eat it off with the cutter itself. No, you can use this to peel the vitreous, And then once its job is done, you can you can use the cutter to remove the sponge that can be done.
I
as
think
well.
I've seen your videos a few years back.
It's
where
published also. We
Yes,
published
yes,
it sometime back also.
Yeah, and that regarding that syringe part, it may not be the human error. It may be the a fault of the syringe itself. Until few years back, I was struggling with the you can say these disposable syringes, and with the injection of PFCl and dye and all, the flow was never smooth. But as soon as we have shifted to BD syringes like 2cc and 3cc and 5cc BD syringes, the flow of the, you can say, introduction of the PFCl or dye is very smooth. So just please change those syringes also.
Actually, Saurabh, you get two types of syringes, one which have a rubber cork and the ones which don't have that, just the plastic is there. So I find those have a very smooth flow, because with the rubber one, it comes like a gush.
Right.
So you do have that variation.
The ones
of
with plastic are
yes,
better.
exactly.
Okay.
Yeah.
Thank you.
And with the constellation, the fluid compensation also can
Yes.
be playing a role. So you're trying to impress, and then it may not compensate sufficiently for you to allow it to be injecting inside. So what I do sometimes is to use a thinner needle as compared to the size of sclerotomy. So if I'm doing a 23 gauge surgery, you can use a 24 or a 25 gauge needle. So there's some sufficient space around the needle for the fluid egress, and so that the pressure doesn't build up. That can also be done.
The same thing we apply when we inject the PFCl. If we are doing that 23, we use that or 25G. The problem with that valve cannula, that if we are using valve, then there would not be a benefit. So just remove the valve and use a smaller gauge needle.
Okay.
Only problem with clamping the infusion is there's no backflow.
Egress, yeah.
So sometimes depending on what we want to inject. If it's going to be BBG, if it's going to be BBG, it's fine. But if you're trying to inject a PFCl, then there's a fluctuation of hypotony, then pressure goes up, then hypotony, pressure goes up. That's what happens.
You can also actually put just a 26 gauge needle, sir, and so that the egress of the fluid can take place through that 26 needle, and then you can just inject.
You mean the 26 gauge needle the other side?
Yeah, anywhere, just like
correct.
this
Okay,
thing.
you mean just
into,
like
It's
exactly.
traumatic.
Exactly.
Introduction of a new needle may be little traumatic. Rather than just we can buy that dual bore cannula. That is another option. That whenever we inject anything, it will go out.
Yeah, but those dual bore cannulas, after
expensive.
some time, they stop working
So,
because it
yeah,
gets blocked with all.
This is the reason we have been shifted to 25G soft tip in a 23G system.
Thank you.
Thank you.